helpful is to start maybe funnelling you guys into, I'm not 100% sure why there's confusion in the, and I'm not trying to sound sarcastic, but if you say that if you're a textbook and I'm talking about depression, I'll assume that you find the depression chapter in here. Again, I'm not trying to be sarcastic, so I just don't understand the exact confusion. Same thing with Stahl. He may mention serotonin in 15 chapters. Therefore, I don't give you a specific chapter because he may mention serotonin in depression. He may mention serotonin in anxiety. Benzodiazepines, they show up in different chapters. So it doesn't really seem like an efficient use of time to say go to this page in the book. I tried giving you some guidelines here. Depression chapter. We're talking about depression. What would I expect you to read? The depression chapter. Same thing with the Stahl. I didn't give you a particular chapter. So these are documents that you just want to become familiar with the how to use. I really don't know now. So without understanding where the confusion lies, it's hard to help you. So get right to it. Psychotherapy and pharmacotherapy. Now, I alluded to this a couple of days ago, but I kind of touched on it. I didn't really explain myself just because I was kind of jumping ahead. I want you to remember that medications, once a depression becomes severe, you have to start thinking about a medical disorder. Right? Something's physically wrong with the body. At that point, all the psychosocial interventions in the world aren't going to do anything. You have to fix the imbalance, the underlying imbalance. That's probably going to be used along with psychotherapy sometime. Now, if you have very mild depression, you throw moderate at somebody and it looks as if they're depressed, but it's pretty benign depression, then maybe you can do biopsychosocial and exercise and peer group and things like that. But if you think there is a true imbalance and they're severely depressed, you have to start thinking about chemical manipulation. Okay? And I alluded to it before, but I recall not being very clear on this because I was trying to kind of plant the seed for later. But this is how you should think about it. ECT, as pharmacists, everybody who's been through my office in the past has at least experienced ECT because there are drugs involved, but we're not going to spend a lot of time on ECT. Everyone's probably seen the movies, where they induce a seizure. It's basically you induce a seizure, you cause a massive release of a neurotransmitter. It's very, very effective for just everything under the sun. Bipolar, psychosis, depression. And nobody knows why. Yes?
Isn't that kind of a shotgun approach a little bit before we are?
Well, yes. However, if somebody was severely depressed and couldn't function, or psychotic and couldn't function, or manic, all of these disorders and they can't function, and you throw them into ECT and they come out as a different person, and then you periodically maintain them, you're going to take it. You're going to take it every time. Trust me. You have somebody that you cannot do anything with. They are catatonic with depression, and you give them ECT, and all of a sudden they're like, I'm back. And all they have is a little bit of a headache, a little memory loss. So yes, it's very barbaric. Well, it's so barbaric, in fact, that you tourniquet the foot off so you can watch the foot seizing so that you know you actually have reduced the seizure. So yes, it's very barbaric. But it works. It works. It's kind of like stoning back in the day, when you got stoned in front of your whole village with true rocks, not stoned like really high, but when your fellow villagers stoned you probably didn't do that again for a while at least, right? I mean, some things are barbaric, but now one of my all-time favorites, 10,000 Lux light box. I have one of these in my home office in the basement where it's started. It's full spectrum lighting, and it activates you. It activates your activating system. I use it a little off-label because I use it for working at night, and I use it for writing grants and stuff like that. So it's a little off-label, but it does provide energy, and it is a relatively benign. If I stare at this thing all day, if my eyes get irritated, obviously they get dried out of our contacts. So I'm not saying it's completely benign, because anybody who wears contacts knows how uncomfortable that is. So I wouldn't stare at this thing all day long. However, in short bursts, it's very effective. Now, if you're using it on label, which is the point of this lecture, it's very effective in the winter, especially in the state of Maine, where it can start at 3:30, in December. This can help. Lux. It's that. Look it up. I don't want to go. I don't have time to go into it. 10,000 lux light box is full spectrum. It's a way to measure how much light's getting to the eye. All right. This is why I don't have time to talk about lux, because we have a lot of drugs to talk about. There are a lot of antidepressants, and you have to know them. There's no way around it. This is about as close to memorization that you get in therapeutics. Drugs like this, antibiotics, or beta blockers, ACE inhibitors, where there's no way around knowing this information. At some level, you have to memorize, right? You have to at some level, but that should not be your centerpiece for how you approach this course. And I don't know, Crystal, is there a better way to say that? Right? You have to memorize to some degree. I don't care where you're at, but it should not be your primary approach, because you'll get killed as you progress along. There are a lot of medications. This comes from the textbook, the 8th edition, I think. I think that's where I got this one. It's mine, it's not plagiarism. I broke it into categories based on mechanism of action, serotonin reuptake inhibitors. Now, when I say SRIs, serotonin reuptake inhibitors, and when I say SSRIs, that's the same thing. Do you remember this last year? It's the same thing. Now, different drugs can have SRI properties, okay? Just because I say SRI doesn't mean I'm only talking about the 6 or 7 drugs that are just selective SRIs. Venlafaxine is also an SRI, but it also happens to work on norepinephrine. Therefore, it would be called an SNRI, serotonin norepinephrine inhibition. All right, so you have to know the medication. You have to know what it does to make use of the terminology. Because last year that caused a lot of problems. Well, SRI, isn't that just these? Well, those are selective serotonin reuptake inhibitors. For venlafaxine, it's also a serotonin reuptake inhibitor, right? They cross each other's borders. This is just a way to categorize these medications to help you conceptualize where they belong. All right? So you have selective serotonin reuptake inhibitors. You have serotonin norepinephrine reuptake inhibitors. You have an amino ketone, which is bupropion. It's the only medication like it that we talk about. You have the triazolopyridine, methazone and trazodone. We're going to focus on trazodone primarily for sleep. There's a new formulation out. We'll get to that. Tetracyclics, mirtazapine. I don't talk with brand names at all. I list them because the book requires me to, but I don't teach brand names at all, even though you're going to be exposed to brand names. But the brand name will eventually fade off, and you're going to still have to know the generic name. That's my reason for it. Yes, doctors still write the brand names because they're getting hammered by pharmaceutical reps that want to prescribe this drug. They know the brand name. I understand that argument. It's reasonable. However, in 50 years, we're probably going to say mirtazapine is not going to say right? There's my reasoning, and that's the end of it. So, tricyclics are all old school. Tricyclic antidepressants, they go way back. We're going to talk about them. And then the monoamine oxidase inhibitors. Way back. All right? Those are the categorizations. And if you know these tables, or at least have a general feel for these tables, you're going to be better off. But I'm going to talk about each of these in more depth. And we're also going to talk about these in anxiety. So you're going to see them twice. You're going to see them today, and then you're going to see a lot of them again in anxiety. So there's going to be some repetition. So hopefully in 3 days, at the end of the day, Thursday, which is now a normal lecture, hopefully you guys will feel, okay, I got this. So, this is another way to categorize them. Well, which medications work on serotonin? Serotonin selective reuptake inhibitors, the tricyclics, venlafaxine, duloxetine. Which medications work on norepinephrine? So this is a slightly different cross-section of the medications. Both of these approaches are purely ways to break them down into a way that you can compartmentalize them and use them. All right? So you start thinking about it this way. If we go back to, actually we're going to go forward to this. We're going to go forward to, hold that thought. You start categorizing it through different mechanisms. You can start pulling these together. For example, venlafaxine and duloxetine are both serotonin, norepinephrine reuptake inhibitors. What's the difference? Does anybody know the difference between these two medications? Does anybody know the primary clinical relevance the maker of duloxetine pushed on the medical community to get it to the market when we already had venlafaxine? Anybody? What? Yeah, so different indication, they're going for a different indication. But if you stay within depression, what is their big claim to fame? Which might have some truth. Anybody want to guess? Do you remember? Duloxetine is supposedly a more balanced serotonin norepinephrine reuptake inhibitor. Venlafaxine actually climbs in dosing from being very selective for serotonin at low doses, and then it picks up some norepinephrine reuptake inhibition at higher doses, and then dopamine even at a high dose. So if you max out venlafaxine doses, if you push it, if you go back to my table, and you look at venlafaxine on here, and I talk about 75 to 225. Once you start getting 225, and there's no hard fast rule, like people differ, but as you start approaching 225 and beyond, you're going to be hitting all three pumps: serotonin, norepinephrine, and dopamine. At low doses, so when I'm talking about a low dose of venlafaxine at 37.5 to 75, I may be just using the selective serotonin reuptake inhibitor at that point. Whereas duloxetine at any dose is a more balanced medication. That said, the clinical relevance of this remains unknown, other than you don't have to titrate. There's no dose titration. The minute you throw on duloxetine, you're in a therapeutic dose. So, is that worth millions and millions and millions of dollars and advertising and everything else? That's a whole different question. Is it novel enough? No. But it's here. You have to deal with it. The only medication on here that blocks dopamine uptake, there's two of them. Bupropion does it normal therapeutic doses, and then, as I said, venlafaxine does it at very high doses. So bupropion and venlafaxine are relatively unique in that of the modern medications, they actually block the reuptake of dopamine. The reason I say that is that if you start talking about the monoamine oxidase inhibitors, they stop the breakdown of everything. So they increase all these transmitters, but they do it by that slightly different mechanism. So you kind of have to, and again, you can memorize these different ways. And again, memorize, use that loosely. Different ways. Do you want to do it by the mechanism of action? Do you want to do it by the transmitter? You have to do whatever works best for you. All right? All right, see ya. So, this is a neuron that you've seen before, a couple days ago, I believe, or just yesterday, I can't recall. Again, I just kind of flew on where you might see some of these medications work. Serotonin reuptake inhibitors work for the serotonin transporter, so the SNRIs, and so the PCAs. You also see intracellularly that the monoamine oxidase inhibitors stop the breakdown of monoamine enzyme, therefore allowing for more dopamine, serotonin, and norepinephrine. Right? Remember these slides from yesterday? Yeah, it was a week ago. So again, just a way to help you think about where these drugs work. All right. Same slide. Serotonin norepinephrine reuptake inhibitors and PCAs that work at the norepinephrine pump. And again, monoamine oxidase inhibitors. Now, when I talk about efficacy, you should be thinking about these neurons. Not talking about efficacy, you should be thinking about the reuptake pumps, you should be thinking about enzyme. Now, when I talk about side effects, you start thinking about all the other receptors that these medications tap into. If you look at the Stahl book, for example, he does a great job of saying, okay, the green square is going to be norepinephrine, and that's what you want. And then there's going to be this red X, that's going to be histamine. Block the red X, and there are side effects that go along with blocking histamine, such as sedation and cholinergic effects. So the Stahl book does a pretty good job of making it into a visualization, a cartoon, so you can see what these look like. Has anybody seen the Stahl book yet? Have you seen figures that I'm talking about? These side effect receptors that he shows you, and then he says this is what that would do. But if you block histamine, for example, you're thinking sedation. If you block cholinergic receptors, you're thinking, did you guys learn that mnemonic, mad as a hat, red as a bee? Remember that? Red as a bee, mad as a hatter. You guys remember that? Huh? Dry as a bone, blind as a bat. Yes. And you have delirium. Don't forget delirium, mad as a hatter. Huh? Okay. No one? Listen. How do you get past cholinergic and not learn that? Who taught you cholinergic?
He's talking about the receptors. Something.
That's all they taught you?
Receptors.
Yeah,
Okay, so
there was some other source that expensive.
Maybe some
again, side effects. Not efficacy, but side effects. And then when you talk about alpha-1 antagonism, you should be thinking about orthostatic hypotension. Now, all these side effects are a very, very important way to choose medication. So in that patient that I told you about that had insomnia, now if I wrote that case, I would talk about a drug that blocks alpha-1, or I'm sorry, well, maybe alpha-1, but histamine, because I want to help him sleep, right? So I would choose something with an antihistaminergic side effect. I would use the side effect as part of the clinical profile, right? So side effects are huge in psychopharmacology because first of all, you try to harness them and use them for what you can. Because in some cases, so one person's side effect is another person's blessing, right? Kind of, there's probably a really poetic way to say that. Right? I can copyright that one, right? Another one person's, yes, I can remember. Yeah, anyway, I'll work on that later. My other. So again, though, you want to use the side effects as the best you can because most of them have side effects. And if you can't use the side effects, then you either have to deal with them or try to avoid them, which isn't easy. Alpha-1, orthostatic hypotension. Are you guys familiar with orthostatic hypotension? Yes? No? Yes. Drop in blood pressure, particularly upon standing. All right. This is another chart from the Piero book that basically shows you, tries to clump some of these drugs together based on what receptors they hit. For example, the older tricyclic antidepressants hit everything, and therefore they have a full list of side effects. Now, who can tell me, other than Crystal, what medications do we have that are basically tricyclic antidepressants cleaned up? No. What medications do we have for depression that are basically the tricyclics cleaned up?
Tricyclics cleaned?
Cleaned up without all the side effects.
With no side effects?
Oh, it's like the second generation antidepressants. It might be.
Well, they're a step in the right direction, but they're not. They're still the secondary means they're still tricyclics. What modern day medication do we have that looks just like the tricyclics without all the side effects. Oh, you guys, come on. There'll be someone in this room paying attention. Look at venlafaxine. Venlafaxine has the exact same efficacy, same profile as serotonin and norepinephrine, except without all of the side effects. So they basically cleaned up the tricyclics, kept the serotonin and norepinephrine blocking properties, the uptake blocking properties, so that that's efficacy, and they got rid of all the side effects. All right, so you start thinking of it that way. Start thinking about these medications in terms of what they block, what they cause in terms of symptom profile, side effect profile, and efficacy.
This is venlafaxine,
And
right?
I'm not going to go over every plus on this, but again, it's a way to see how you can see that.
Yes, I know that.
Yeah, that's it.
All right, this is basically a pharmacokinetic table. Again, some of this you just have to know. A lot of this, if you're in a real clinical situation, if I'm specializing in psychopharm, I'm going to know this. If I'm specializing in something else, I'm going to be able to at least look it up quicker. But you're going to want to, a couple of things in here that I think you are important enough to highlight for this class. Something like, does anybody see something unique about any of the half-lives of any of these medications? Right, fluoxetine has a half-life that you're talking about in days. So fluoxetine may be a serotonin uptake that you use for somebody who doesn't take the medication appropriately. Somebody who's in periods, who don't remembers half the time, somebody with a busy lifestyle, et cetera, et cetera, et cetera. That would be something that you should clearly know from this table. Another thing that you should clearly know from this table, in psychopharm, you don't do a lot with protein binding with the antidepressants. It's not something that causes much of a clinical concern, so we're not going to really deal with that. You can see that the tricyclics have pretty poor bioavailability, but again, that's not going to be something that you're going to be overly concerned with. So something with a short half-life would be useful. For example, if I'm going to use trazodone, or because trazodone is one of the most common sleep aids, or doxepin. What's the problem with using? You have one that has a pretty short half-life. Right? Trazodone's half-life is relatively short. Doxepin, also very sedating, has a very long half-life. If I want to use something for sleep, but I don't want them to have a hangover effect, I'm going to lean towards something like trazodone. However, if someone's very anxious with their depression all the time and they can't sleep, maybe a long half-life is not going to be all that bad if you're kind of sedating them around the clock. Because if they're very agitated, they have insomnia, early morning awakening, they're agitated, they're anxious, maybe a little bit of sedation is not a bad thing. That's why you also see something like that. So you have to know from the patient case, is this someone, say you have someone who can't sleep, but they're very tired throughout the day, which happens all the time. People are depressed, they can't sleep, they're not sleeping well, they're very tired throughout the day. If you were going to give doxepin to that person, it might be a bad choice because they're already tired throughout the day. You just want to turn them to sleep. Right? The first case that I gave you, that might be a case where you covered wrong. Good question. Thank you. There are some clinically relevant drug interactions with the antidepressants. Fluvoxamine is the biggest offender because it potently inhibits both 1A2 and 3A4. You guys have had some psychopharmacology? Yes? So, fluvoxamine and paroxetine are very potent and very specific at blocking 2B6. 2B6 is a pretty big player, so you're on a beta blocker that is metabolized to 2B6, you're on paroxetine, the blood pressure plummets. It's a very common scenario. Fluvoxamine, how many medications are metabolized by 3A4? You use a 3A4 inhibitor, such as fluvoxamine, is one of those medications that causes all kinds of problems. And remember, 3A4 does the lion's share of metabolism, so that can be very problematic. Again, you simply have to know no way around it. Now I'm going to go drug by drug a little bit here, and keep this apart. Serotonin reuptake inhibitors, without a doubt, side effects that happen are likely, you can almost expect them to happen. And I use almost expect them to happen. Nausea, GI effects, because you have a lot of serotonin in the gut. Nervousness and insomnia. Do you remember the talk? We were talking, what was your name? Do you remember the receptor sensitivity scenario I gave the other day? Tyler was talking about, we were talking about the difference between efficacy being delayed and side effects at the beginning. If you give a serotonin reuptake inhibitor at the beginning, you're assuming, somebody else had talked about the deficiency. Remember, I was bouncing this off somebody else. You're talking about when you first go into treatment, there's probably an upregulation, right, of receptors because the body's craving. Who was that? Who we had this conversation? Yeah, remember that? You have a bunch of receptors because you're craving homeostasis, in other words. And then I give a drug. Now I have elevated receptor profile, and I have drug in the system. Well, it's too much. It's too much of a good thing, basically. It's kind of an oversimplification. But then as you get those receptor changes, things normalize. Things downregulate. You take the brakes off the presynaptic, you downregulate the postsynaptic, and things seem to work more efficiently. They look more normal. Initially, though, insomnia and nervousness are almost expected a little bit when you first start an antidepressant. Sexual dysfunction, serotonin wreaks havoc on both men's and women's sexual drive and libido. So any serotonergic medications can be problematic, so it's very difficult to get around. With some exceptions that we're going to talk about. Fluoxetine is generally thought of as the most activating antidepressant. Now, if you really delve into this, I'm not going to test you on this. Fluoxetine also has some slight inhibition of the norepinephrine reuptake inhibitor pump. So there's some belief that maybe it's more activating because you're also increasing some norepinephrine, but it is a commonly held belief that fluoxetine probably is the most activating. Another caveat, paroxetine was being plagued by tons and tons of problems. People having withdrawal phenomenon from it. What they've done is, extended the release profile, maybe, try to get flatter, broader plasma over time profiles. But paroxetine, if you look at the drug itself, paroxetine is definitely the medication with the most withdrawal. You generally consider the serotonergic medications weight neutral. Most medications in psychopharm cause clinically relevant pain that we'll talk about when we get plenty of bipolar. Serotonin reuptake inhibitors, weight neutral. And one of the biggest, most important things to remember about the serotonin reuptake inhibitors, they have a very, very wide therapeutic index. They're very safe. It would be very hard to hurt yourself with just serotonin reuptake inhibitors. That's not true for all. Serotonin syndrome. Now, when I talk about serotonin syndrome, this applies to all antidepressants. Again, this is from the Piro textbook, so you can look at this more if you want. There's some more explanations surrounding it and references. If you combine medications that have serotonergic mechanisms, you're at risk for serotonin syndrome. Serotonin syndrome, remember, serotonin modulates, has an impact on body temperature. It has movement because there's a relationship between serotonin and dopamine that we haven't talked about that hopefully you will in schizophrenia. It has a lot of, kind of more, if you remember all the projections, Garlic, we were talking about the projections you were asking yesterday. If you think about those diffuse serotonin projections, they project onto a lot of different brain areas. If you start cranking up serotonin with multiple medications, you really cause havoc. You end up with serotonin syndrome, and you're usually looking at things like muscular, tremor, clonus. And again, I would spend some more time. If you don't go into the Imperial textbook, read this. There's literature going back forever on serotonin syndrome. But it's potentially fatal, right? If you have muscular problems, you should always be thinking if you have muscular problems caused by a drug at high temperatures, what should you be thinking about immediately? What could kill you? Muscular problems and elevated temperature. What can kill you from that? Or what? Think about the combination of fever and muscular toxicity. There's something that should immediately jump to mind. Fatigue.
Seizure.
You know, when you have a muscular problem and you're having massive muscle breakdown products in high temperatures, you should start thinking about acute renal failure, rhabdomyolysis. You guys learned about this yet? Yes? No? If your muscles are
Rhabdomyolysis.
muscle contractions abnormal, and you start getting muscle breakdown products, your body can't clear, in combination with high body temperature, one of the next stages of progression in that scenario is rhabdomyolysis, which is muscle breakdown. Your kidneys cannot clear that, and you start damaging. You can cause acute renal failure from the proteins from the muscle breakdown products that you're not clearing. So you kind of think of a progression. You think, especially for this class, if you think for my section, you hear the words high temperature, muscle breakdown, you should immediately be thinking, I got to save the kidneys, right? I got to protect the kidneys. Hydration, cool the body, right? Hydration, cool the body. If you're dehydrated, and you have tons of muscle breakdown products, that's a disaster. All right? These serotonergic drugs, that's the biggest danger of using the serotonergic medications, is that if you combine it with another serotonergic medication, there can be trouble, and the medication doesn't have to be another antidepressant, right? Dextromethorphan is an opiate, right? It has serotonergic properties that somebody may not know about, and they prescribe a serotonergic inhibitor with that medication, and then problems potentially.
So why can't you overdose on one medication? Why
Who knows? But you can give you can max. The thought probably goes something along the lines of serotonergic inhibitors have a ceiling effect, because if you block all the pumps, eventually you can't block more pumps. But if you start using serotonergic mechanisms specifically, they have a different mechanism. If you were to use a monoamine oxidase serotonergic inhibitor or a serotonergic agonist like a migraine med, now you have different mechanisms of action. So that's likely where it comes from. Good question.
What if someone does have serotonin syndrome? Use water and make it go up, or what?
No, you're going to cool the body, you're going to hydrate. Those are the big ones, hydration and cooling. To start, you may end up having to give, we're going to talk about a similar situation with MAOIs, where you may end up even giving like an IV, like codeine, metronidazole. We're going to talk about some other potential options, but usually serotonin syndrome is more preventative. You want to keep your kidneys flushed, you want to keep water, keep fluid running through, and keep your temperature down. I don't go into it here because it's so, the chances that you're going to see this are pretty rare, but you may use something like dantrolene. There are things you can do, but we're not going to go into it. The closest that I get to it at this level would be more like stimulant intoxication or neuromuscular, some of the stuff we're going to talk about with MAOIs, where maybe we use like an alpha beta, some alpha beta, or hold that thought for a minute. substantially would be a good one. Then the vaccine, I'm going to let you read some of the minor details, but again, they're just like the tricyclics, they're cleaned up. So they work at serotonin and norepinephrine without all of the side effects. They're serotonergic at every dose. You need to think about things like, same thing with serotonin reuptake inhibitors. You need to think about the nausea, because you have serotonin in the gut. You need to think about sexual dysfunction, because serotonin. When you augment serotonin, immediately with antiandrogen, you should think about a negative impact on sexual function. And then there is some dose-related increases in blood pressure, because remember, at the highest dose, you're increasing dopamine and norepinephrine and serotonin. And dopamine and norepinephrine are the two primary immune systems, nervous system, right? Or norepinephrine, epinephrine, I should say. So norepinephrine is sympathomimetic, right? Right? You agree with that, Heather? Duloxetine, again, I'm going to let you read some of the subtleties. However, the big difference between this and venlafaxine, or the big claim, is that this one is more balanced, that you don't need to dose titrate to get to that serotonin and dopamine reuptake inhibition. You actually get both in the first dose. Side effects should look very similar. Now, another thing to add there, when you think about norepinephrine side effects, you can, in a way, kind of think about sympathomimetic, right? If you were to take, everyone in here probably taking like Sudafed, right? Sudafed causes vasoconstriction in the nose, a lot breathe better. It causes some people to be restless. The mouth gets dry, because that's a sympathetic nervous system response, right? So when you think about the side effects of norepinephrine, the analogy would be something like Sudafed, sympathomimetic. Bupropion, again, read some of the subtleties. What I really want you to focus on, what I really need to focus on for bupropion, on the subtleties, is the seizure risk. Bupropion has a very, very clear relationship with seizure activity. If you dose, depending on the product, if you dose somebody too high, or the peak's too high, bupropion, there's a very real possibility of inducing seizure activity. And it's there, and you really have to pay attention to it. No way around it. Again, because it's dopaminergic and noradrenergic, you do see some of the sympathomimetic effects. Because it's the most dopaminergic and noradrenergic, it is thought to have some of the, and we didn't get to schizophrenia yet, or bipolar, but maybe it can be associated with manic-like symptoms, right? Increasing dopamine and norepinephrine. That'll make more sense after you go to bipolar and schizophrenia. But when you think excess dopamine in the brain, you should start thinking about potential mania, psychosis, so agitation. So when you think about a drug like bupropion, you should be thinking activation, potential for mania, potential for psychosis, all of these activating type side effects, all right? Trazodone and methazodone. Up until there was recently a new version of trazodone marketed that's supposedly going to get around a lot of the side effects. The problem with trazodone, I think it's on the next slide, is that it is so highly sedating and causes so much orthostatic hypotension that you could never get anybody to a therapeutic dose. Now there's this new release profile that they're claiming you can get people a therapeutic dose, but it hasn't been out that long. We'll have to kind of wait and see. However, at this point in time, you will see trazodone commonly used in a regular form for sleep because it is so sedating. So you should use low doses for sleep. It is the number one reason that you would see trazodone, or the overwhelming reason you would see trazodone at this point in time. And maybe that'll change. Maybe this new trazodone release profile will stand the test of time and be highly effective medication for depression. Maybe. It does not cause sexual dysfunction like the others do. So if that new release profile does work, then one of the big potential advantages is it doesn't cause sexual dysfunction because not only does it have a reuptake inhibition property, it also is a serotonin agonist. So it's thought that by you have two serotonergic mechanisms, and that by having the serotonin antagonist properties as well as the reuptake inhibitor properties, that you get an antidepressant effect, but you also decrease some of the serotonin side effects. Again, it's never, up until very, very recently, it's never been dosed high enough that you can see that work because of orthostatic hypotension. Alright. Methazidone, pretty much gone at this point because of reports of liver failure. Maybe people that were once on it that was fine for 30 years and didn't want to switch. Maybe you'll see some weird cases, but pretty much at this point done. So that class of medications is not the, as an augmenting agent for sleep out of the two, they haven't been the most successful for depression. Mirtazapine, completely unique among all of the antidepressants we talked about. Do you remember we talked about heteroreceptors, how they could have an heteroreceptor presynaptically that would respond to both serotonin and norepinephrine and put on the brakes for the neuron? You guys remember this? I've seen some heads shaking and other blank stares. Mirtazapine is an alpha-2 antagonist. So what does that do? Who's going to tell me what a presynaptic alpha-2 antagonist does? Increase firing. How does it increase firing?
Because it's relaxing the brake, basically.
Braking, it's stopping the brake. It's antagonizing the brake, so the cell can fire. So therefore, because it responds to norepinephrine and serotonin, the thought is that you can actually increase firing of both serotonergic and noradrenergic neurons. Very unique. Other thing about this medication, it's one of the few antidepressants that we talk about that doesn't have extensive hepatic metabolism. Primarily renal. Causes very significant sedation and waking. Alright, very significant sedation and waking. And here's an interesting thing. The noradrenergic effects of blocking that presynaptic alpha-2 are so prominent that at higher doses you get so much norepinephrine you can actually squash the sedative effects. So this is one of those cases where lower doses are actually more sedating than higher doses, because at higher doses you have so much noradrenergic output that you can actually override the sedating effects. Moving. TCAs, they're still one of the most effective antidepressants known to man. However, they have too many side effects. So you'll see these used for patients that don't respond to other medications. You'll see low doses of TCAs used as sleep agents. So again, they're kind of used as augmenting agents at this point in time. A whole bunch of side effects. Again, as we talked about before, a few of them are actually dangerous, such as they lower seizure threshold. They have cardiac antiarrhythmic effects, so they actually can interfere with cardiac conduction. So, if I'm dispensing TCAs to somebody who's suicidal, does that worry me? Very obvious. Yes or no? That doesn't worry you? So if you can stop your heart with this medication, and you're suicidal, that doesn't worry you? Do you want to rethink the answer? Right? They're dangerous. They're dangerous medications.
Even if a person, if the person has cardiac problem, obviously, but if they're a relatively healthy person, it still have that effect?
No, the TCAs have antiarrhythmic effects. So it doesn't matter who you are. If you take enough of them, you can disrupt the normal conduction of your heart and kill yourself. So that's another big problem, right? Nobody wants to suspect. They're very effective, but they can kill you, right? It's a dangerous game. I talked a little bit about this in the chart. You can take a look at that. This is one of the few cases in depression you can actually do therapy monitoring, therapy drug monitoring. You can look at those numbers. The other dangerous side effect I wanted to talk about, other than serotonin syndrome, was the hypertensive crisis. Because monoamines increase norepinephrine and dopamine, if you give another medication that activates the sympathetic nervous system, you can cause a dangerous increase in the sympathetic system and cause a hypertensive crisis, which can kill you. Again, you see the headache, you see stroke, blood pressure increases, not a good thing. All right? So that's like a pharmacodynamic interaction where you're increasing the sympathetic nervous system way too much. Serotonin syndrome, we already talked about this. Now, another big thing with MAOIs is there's not only drug interactions, there's food interactions. Now, I always make light of this. I make light of it because to me this would be like, for lack of a better term, kind of like hell on earth. You can't eat cheese, you can't drink wine, you can't drink microbrews, you can't do anything that a lot of us consider fun, because those foods, all these fun foods, can be tiring. And tyramine has a pressor response. If you take a monoamine oxidase inhibitor and you can't break down tyramine, you again have increased your sympathetic nervous system. And if you look at the chapter in the book, I kind of break it down into high tyramine food and low tyramine food. The point being, if you give somebody a high tyramine food and they're on an MAOI, that's bad, very bad. Dangerous. Alright? So take a look at that chart that I wrote in the book. There's a new patch. Yes?
How do people correct it if it happens for someone happens to be at this point and then you find out how do you correct it?
When you get to any of these medical emergencies, you have to think about the product, right? In this case, we're talking about the pressure response. We're thinking about an elevated sympathetic nervous system. So there's a lot of data that, for example, what not to do is, these are a place to start. You wouldn't give unopposed beta blocker. A beta blocker that was selected, because then you have unopposed alpha actions, right? You familiar with pharmacology? One of the things you don't do in the state of sympathetic overdrive is you don't give a beta blocker in isolation, because then what you have is unopposed alpha. So you block beta, but now you unopposed alpha. Constriction. It works. The thought is that you would do something like benzodiazepines to slow down the sympathetic nervous system. You can give nitroglycerin type products to relieve the pressure on the system. You can give an alpha and a beta blocker, like tolamine, relieve the still in beta or betalol. But you basically want to dampen the sympathetic nervous system altogether. It's a good question. I'm just trying to get it in fast, which is not easy. And we can revisit some of this. Anxiety is very straightforward over the next 2 days. So we'll be able to revisit some of these things that I had to fly before I leave. Because there's a lot going on in depression. So the anxiety, we'll be able to, especially the 2 days, we'll be able to handle. There's a new patch, a sledgehammer patch, and the big benefit is it allows you to still metabolize tyramine, yet inhibit monoamine oxidase B, because there are 2 subtypes. If sledgehamine, so think of it, I don't want to go any deeper than that right now today, because we have to keep going. Sledgehamine patch allows you to break down tyramine and still get an antidepressant response. And we're going to have to revisit this. We're going to have to revisit this tomorrow. St. John's wort, the reason I put it in here is because you can buy it over the counter, and it induces 3A4. It induces 3A4. There are so many clinically relevant drug interactions that St. John's wort can cause, yet you can grab it over the counter. It's kind of an interesting phenomenon. Choosing medications, we're definitely going to, this is a very important thing, so we'll talk about this one tomorrow. We're going to talk about this tomorrow. and this is from the Bureau textbook we'll talk about this. So I'm going to begin at the end of this lecture, just so there are a few important points.
What's this discussion
Okay? And you can ask me
for the
questions.
Medcam? Okay. What was the discussion about?
Discussion. What do you mean discussion?